start and we can start.
Sure.
A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Alhamdulillahi rabbil alameen. Today we'll be talking about how to communicate to elderly with depression and diagnose them and treat them. This presentation was given to me by Lundbeck, Pakistan. So I was not able to edit it much. So I'll be presenting the same because unfortunately of some personal circumstances, I was not able to do much about the presentation. So I hope I'll be able to do justice with them. I request all of you, tak raat hai. So unfortunately, my wife is having some problems. So dua kijiyega unke liye. So we'll start the presentation, and if you people have any questions, you can type your question in the chat box. I will try to keep looking at it whenever possible. So, and respond to it. There are a few slides which contain some questions as well during the presentation. And if somebody wants to intervene, they can unmute their mic, talk, and then we can discuss further. So no hesitation, you can stop me anytime you want to. And let's hope we'll be able to learn something from today's presentation. So it is the art of disclosing depression to your patients. When I was going through this presentation, I unfortunately was not able to see too many things related to this, but however, I will communicate my experience with you. Na ख्वाहिशें ना जुस्तजू पसयाई ना मेरे रूबरू तेरे वास्ते मैं कुछ नहीं तेरे वास्ते बस तू ही तू. So let's pray that we in this holy month of Ramadan will be able to do the justice what is needed from us and do something which is again good for us in this dunya and akhirah as well. Depression in elderly, why we pay attention? So long time back, about say 25 years back, when I started practicing in Pakistan, early days of my practice, I started talking about Alzheimer's dementia, that I'm seeing Alzheimer's dementia in people coming to the clinic and in hospital as well. But unfortunately, at that time, some of my senior colleagues, they laughed at me and they said the dementia is not the problem of Pakistan, it's the problem of the developed countries. After another 5 years, they started accepting it. Even now, we do see hordes of patients who are coming with the cognitive impairment. We try to diagnose them with dementia and other associated illnesses. Even people go to neurologists, but they are not treated the way they should be treated for these cognitive impairments. So there is still a lack of acceptance that people in our society in Pakistan are developing problems related to the age issues. And unfortunately, by the time they are too much complicated and they have multiple complications related to dementia, then they present to us. So I always give example कि जब तक बाबा जी या अम्मा जी कोई ऐसी हरकत नहीं करते जो कि सोशल नॉर्म्स के लिए नाजेबा करार दी जाती, तब तक वो साइकियाट्रिस्ट के पास नहीं आते, which is unfortunate. So when Babaji starts sexually approaching to the bahu, then of course people realize that there is something wrong with this man and they take the person to the psychiatrist. Same goes ke amma ji kapde utar deti hain publicly, then they realize that there is something wrong with the person and they bring. By that time, unfortunately, things are very complicated. And then, of course, the prognosis and outcome is also complicated. Earlier the diagnosis, the better is the treatment. That is the motto, and this is what we convey to most of the neurologists, physicians, and other people as well. And surprisingly, everybody believes in it, but when it is an actual practice, we don't do that. So we still don't see too many people getting appropriate treatment for the problems which are the elderly people are facing in our society. So when we talk why it is common, now this is Western data, and unfortunately, we don't have much of the data in Pakistan. About a year ago, I wrote a chapter in a book related to dementia in developing countries, and I was trying to locate actual possibility of cognitive impairments in elderly, and very few studies, very few studies we can get from the areas like Pakistan, India, Bangladesh, and other places like that. This is again unfortunate that without data proving anything is not appropriate. But it is said that 46% of the people home residents suffer from some type of depression, and of course related problems as well, elderly. Now, here in Western world, we do have old age homes, we have retirement homes, and even in my city, there are at least 10, 12 retirement homes. They are big homes with multiple flat-like situation, where every possible services are provided to the people who are elderly. In Pakistan, we still unfortunately don't have those kind of facilities. So facilities like they should have a walk-in bedroom where they don't have to climb the stairs. The washroom are secure, so there are handlebars to hold them and sit and get up. The beds are in a way that they can pop into the bed and get out of the bed comfortably. So there are very small things that matters when the person is elderly. And as you can see in the picture below this slide, that they need help with walking, they need help in companionship, they need help in communicating, they need help in relationship issues. So all of those things are very significant. And when things do get complicated, then of course, we are compromised in a number of situations. So we have to understand the dynamics of all of the situation before we start treating them. Depression worsens general medical condition. Now, this is a known fact as well. If a person is suffering from major depressive disorder and he starts suffering from some physical morbidities like diabetes, like blood pressure, like myocardial infarction, heart failures, or post-stroke syndromes, then of course the depression and the physical comorbidities worsen the prognosis and outcome in any of the possible diseases. And this is unfortunately again a complication. So depression in elderly, how should we manage it? So in management, everything comes in. How do we assess? We have to understand the etiology, the pathology, the psychopathology, and the treatment strategies with the outcome and prognosis as well. So by the time you start assessing somebody who is elderly, then of course you have to take care of everything related to it. And pathophysiology and etiology includes the physical morbidities as well. So we know that again, as depression worsens the outcome of the physical morbidities, the physical morbidities also can complicate the depressive symptoms. So it's a vice versa situation, and we have to understand that dynamic as well. Now, whenever we want to treat people with major depressive disorder and they have some physical morbidities as well, it is always seen that as soon as the depressive symptoms improve, the outcome for the physical problems also improves significantly. So again, as I mentioned, they are both linked. If one is treated and the other is not, the outcome is compromised. And if depression is treated and the physical morbidity are unfortunately complicated, again, the depressive symptoms won't improve significantly. So it's basically a liaison service between a physician who is managing the blood pressure, the stroke, the other associated factors, and a psychiatrist. Again, the communication between two physicians and psychiatrists is a big issue in our society as well. Whenever we want to convey something to the physicians, they don't believe in us. They feel, oh, ye to psychiatrist hai, isko kya pata. And unfortunately, we do have problems associated with it. So whenever I try to communicate, I always talk to them, try to explain to the physicians that this is the condition, this is what I'm trying to do, and that needs to be done. Of course, there are ifs and buts associated with it, but we try to do whatever is best for the patient. Okay, now this is a question from the group which is attending this. Question is management of depression, I'm sorry, I cannot read it completely because of some, okay, now I can see. So depression in older population different from managing depression in younger patients. So is there a difference when you are treating a person who is 24 to 30 years of age, or when you are treating a patient who is about 60 plus, 65, 67, or 70 years old? Is there a difference? You can type your questions here. Yes, considering the impact of aging on pharmacokinetics. Yes, considering the higher incidences of medical comorbidities. Yes, considering polypharmacy is more common in older population. Yes, all of the above are correct. So I got two responses. One is D, all of the above, and second one is D as well. Well, absolutely right answer to the question. All of these phenomena, like the pharmacokinetics, is unfortunately complicated. The medical comorbidities are very high. And we have seen that people, as they grow older, they start having multiple physical morbidities and multiple medication. Now, this is another debate that I usually have with the physician. So when a person goes to a physician for the treatment of blood pressure, they usually prescribe 2 to 3 antihypertensive medications. And I always ask, why 2, why 3? And most of the time I get the response that, yes, because this is an international guideline. I do agree that it's an international guideline to give a combination of antihypertensive medication to people who have blood pressure in older age, but can we try first-line monotherapy? And if it won't work, then we should go for some further polypharmacy situation. So unfortunately, then the things are complicated because there is blood pressure, there is diabetes, there is arthritis, there is visual disturbances, there are hearing problems, there weakness of the muscles, their diet and appetite and stomach is problem. And if you give 2 medications for everything, then Babaji around the age of 70 is taking about 14 medication in total. All of these medications have interactions with each other. They do have competitive inhibition in the liver. So the enzyme system in the liver is compromised. So unfortunately, it creates further complication in the outcome and management of the people. Then impact of aging on pharmacokinetics, the first and foremost thing. So the first pass metabolism decreased for high extraction drugs. So the bioavailability is decreased. Then because in older population, there is less volume of the body mass, the half-life of the drugs, which are again lipid soluble, is complicated as well. So that is giving more complications. So we have to understand that if a taking the same medication age of 70 can have variable responses because of the lipid solubility of the drug, because of the less volume of the body mass index, etc. In addition to that, there are further complications related to albumin, alpha-1 glycoprotein, hepatic metabolism, and renal excretion, of course. So the kidneys are not as good as they are in the younger population. So the excretion of the drugs is complicated as well. And we have to take into that consideration as well, that this is one of the complications. Faiz Ahmad Faiz का एक गजल है, अब जो कोई पूछे तो भी तो इससे क्या शरह हालात करें, दिल ठहरे तो दर्द सुनाएं, दर्द थमे तो बात करें। शाम हुई फिर जोश कदा ने बज़ में हरीफा रोशन की, घर को आग लगाएं हम भी रोशन अपनी रात करें। Unfortunately, by the time you are in 60s and 70s now, in the Western world, people say that the life begins at 60. But in Pakistan, actually, the life ends at 60. In Western world, why it is said that life begins at 60? Because people at the age, यहाँ पे अगर आप सड़कों पे देखें तो ज्यादातर फरारी गाड़ियां ज्यादातर उन लोगों के पास होती हैं जो 60 से ऊपर होते हैं। ये आप इसको मजाक में ले लें या सीरियस ले लें, बट इट्स अ फैक्ट कि 90% गाड़ियां जो लग्जरी गाड़ियां हैं, स्पोर्ट्स व्हीकल्स हैं, महंगी गाड़ियां हैं, वो 60 से ऊपर के लोगों के पास होती हैं। क्यों? क्योंकि बाय द टाइम दे आर अबाउट टू रिटायर, दे गेट अ ह्यूज अमाउंट ऑफ मनी एज अ पेंशन. So they want to enjoy their life, so they buy expensive vehicles, they travel a lot, they move around, they gamble as well, and so they say the life begins at 60. In our society, back in those countries, by the time a person retires, people start saying, "Eh, hun baba ho gaya, eh kise kamdani reh gaya." So the money he has is not his own, actually. It is actually the money for the children. The resources he has, they are gone because they are not resources for himself, because he's a baba, there is no requirement for it, but he's an amma, and whole of the resources are exhausted by the children. So किसी से सिफारिश करानी है तो बाबा जी की सिफारिश चलेगी, किसी के घर सोशलाइजेशन के लिए जाना है तो अम्मा जी को सोशलाइजेशन के लिए एज अ शो पीस साथ लेकर जाना है. But if you talk about their quality of life, they have money, they have resources, they have children, they have families, but their quality of life is just that they go to the mosque, मुसल्ले पे बैठ गए, नमाज पढ़ ली, अल्लाह अल्लाह कर ली, और ज्यादातर कॉन्सेप्ट यही है कि इस उम्र में अल्लाह अल्लाह. और मेरा ख्याल है कि हमारे मजहब में ज्यादा यह है कि इबादत जवानी की, जब आप में जान हो उस वक्त की जो इबादत है वो दिल से है. जब बुढ़ापे में इबादत की तो आखिरी वक्त में अल्लाह को याद किया तो क्या किया. So again, this is just my viewpoint. You people may disagree with that, but just I'm telling you, giving an example. Of course, I'm not saying that you should agree to it 100%, but I believe that we have to change it. We have to change that concept that people start believing generally in our society. Age-related changes in drug clearance and half-life. So unfortunately, whatever the drug a person above the age of 60 is taking, it is cleared in a longer period of time. So if the half-life of a drug is, say, 10 hours, in a person who is 60, it will be probably 12 hours. In a person who is 70, it will be probably 14 hours. And in a person with 80, it may be going up to 20 hours. So as you grow older, the clearance rate is unfortunately reduced and the plasma half-life increases because of, again, complications of other associated factors. Comorbidities, again, as I mentioned, they're very common in this age after 60. So people do have asthma, diabetes, heart diseases, hypertension, arthritis. They develop different kinds of cancers. They have COPDs, they have ulcers, they have atherosclerosis. So many things are happening when person is getting old. The joints are not giving, again, as much strength as they should be. And people start walking with difficulty. They stop walking, actually. But surprisingly, this is very surprising, but I'm amazed if in Pakistan, you go to Model Town Park in Lahore, people who live in Lahore would be able to understand. In the morning, फजर की नमाज के बाद वहां पे बेशुमार ऐसे लोग जो 60s और 70s के हैं, there is a category of the people of that age who actually are following the Western standards, but those people are very few educated and from a very different class. Majority they again are unfortunately considered to be old and good for nothing. Polypharmacy is prevalent in elderly. As I mentioned to you, people do write multiple drugs, and those drugs are unfortunately complicated in other situations. Geriatric population is more sensitive to effects of polypharmacy because, one, sensitivity to the drugs, then exaggerated responses to central acting drugs, so they compete with each other. So they have competitive inhibition at certain receptors levels, and sometimes, unfortunately, they have agonist responses to certain drugs which are affecting the receptors. Baroreceptor responsiveness and sensitivity leading to increased risk of postural hypotension and hypotension, then alteration in absorption because they have stomach problems, they cannot eat too much, or they eat very restricted amount of food. And again, the food is full of cholesterol, oily, and otherwise. So the healthy diet is unfortunately compromised as well because of the dentures as well. So they cannot chew what they should be able to swallow, and dental hygiene is compromised in Pakistan most of the time. So I don't know what's the reason. There are so many dentists in Lahore from every level, from cheaper dentists who are unfortunately serving the community with less amount of money, and they're expensive dentists as well, who charge probably hundreds of thousands of rupees for a single tooth, which varies. But affordability is not there. People feel कि अच्छा दांत खराब हो गया इसको निकाल के फेंक दो. They don't want to preserve the tooth. They don't want to make sure that the teeth are appropriate. And by the time the people are around the age of 60 or 70, उनके मुंह में दांत होते ही नहीं है, और फिर जब आर्टिफिशियल उनको बत्तीसी लगाई जाती है तो उनके खाने पीने में और कॉम्प्रोमाइज हो जाता है. और जब वो खाना पीना कॉम्प्रोमाइज होगा तो ऑब्वियसली उसका इम्पैक्ट इन सारी चीजों के ऊपर भी आएगा. आई होप आई एम मेकिंग सेंस आउट ऑफ इट. Impact of polypharmacy in geriatric population. Now, these are really, I'm talking about just the common things that I see in my clinics, and maybe again, you people can share more with me if you want to share it, because everybody has a different experience. What I'm saying, they may have different experiences as well. So polypharmacy and multiple comorbid conditions are the risk factors for adverse events. Now, we all know that again, multiplying multiple medications and having drug interactions. So a patient who's having a cardiologist prescription who has given about 5 medication, a gastroenterologist prescription who has given 3 or 4 medication, and then a rheumatologist or orthopedic physician who has given 3 or 4 medication, and then they come to psychiatrist for variable again symptoms, and then we add 2-3 more. So the total number of the pills goes up to 14, 15, 16, or 18, which I believe is not justified. So the first thing I do in my, when I'm seeing patients, these patients, I just want to make sure that the irrelevant drugs should be stopped. So my job first is to convince them to reduce the number of the medication and then get the treatment, rather than multiplying the drugs more and more and things that are getting complicated. And this, unfortunately, adverse event actually account for 10% of emergency visits in the elderly. Now, this is again a Western figure. So in Pakistan, how much it is impacting the elderly, I don't know. But what I see, it's more than 10%, probably 40 to 50% of elderly people who I am seeing, they need adjustment of their medication. And I do make those changes in actually seeing the patients. The first thing I do is that. So when this slide actually should be the crux of the presentation, because this was the topic. And unfortunately, this is just one slide, which I'll be talking on the topic, tips on disclosing depression to your elderly patients. Usually, we are not communicating to the person, the patient, the elderly patient. We are communicating to the family, because no one above the age of 60 comes alone to the clinic in Pakistan. They are always brought by daughter-in-law, son-in-law, son, daughter, or somebody else in the family. Even the wife is most of the time not there, and the wife comes most of the time, the husband is not there. And I always ask this question, where is your husband? He's home. Why he's not here? But he is living with you in the same room, and he is not again there in the clinic to understand the problems his wife is suffering from. This is unfortunately bad. So I always emphasize कि अगली दफा आप अपने खावन को साथ लेके आइएगा, या अगली दफा आपने अपने बेगम को साथ लेके आइएगा. सारा वक्त बेगम आपका ख्याल रखती हैं, आप उनको साथ लेके आए, and then we should talk about it कि क्या situation है. So the simple formalized treatment goals. So we have to sit with them. We have to tell them that these are the medications you are taking. This is what is happening to you. And this is how the things should be, in a very simple way. But most of the time, it's actually the daughter-in-law who's taking care of the father-in-law. And she asks the question, ये क्या हो रहा है, ये कैसे ठीक होगा, ये तो ये करते हैं, ये वो करते हैं, ये गिर जाते हैं, ये कुछ चोट लग जाती है, ये गुस्सा खाते हैं, ये चाय टाइम पे नहीं पीते, things like that. And we have to make them understand that this gentleman is not doing anything with his own choice. Actually, this gentleman is having some problem that needs to be addressed. Second option is the choice of treatment. Now, this is complicated. Choice of the treatment. We have to choose the medication which is a single drug, one, which won't give him postural hypotension, drug interactions with other medications. It should be safe as far as the renal condition is considered, and it should not introduce any other pathology related to it. Now, choosing a drug which is a single drug and addresses all of these issues, sometimes it's get difficult. So again, taking family on board, taking the caregivers on board, and making sure that they understand what you feel should be the appropriate approach to the management. They should be able to understand that, and then we should process it. So be aware of the drug-drug interaction, consider the side effects, good patient information sources, and family. Now, invest, well, Google is unfortunately a very bad doctor, and I always say कि अगर Google इतना ही अच्छा डॉक्टर होता तो हमारी जरूरत ना पड़ती. लेकिन most of the time, this middle-class educated families, they search on Google, they try to put the symptoms there, and they come up with the diagnosis, which is again, unfortunately complicated. So I have to make them understand in simple value. I usually discourage them to read the literature on websites, because जब भी आप Google पे कोई भी सर्च कर देंगे कि अम्मा दी जुती के थे, Google always comes up with the answer. And unfortunately, those answers are not relevant to the question that you are asking. And there is so much irrelevant things that if you start reading them, आप बड़ी जल्दी अल्लाह पे भी भरोसा आपका उठ जाएगा. So try to be careful what you are reading in Google and in these search engines. So I am always skeptical about giving information to the websites to the patients. If I have to give the information, I specifically give them the website, that this is the website you should go and read, rather than any other website which is popping up in the Google. Or most of the time, I try to give them the information by myself. अमजद इस्लाम अमजद की एक नज़म, अभी तो रुत बदलती थी, अभी तो फूल खिलने थे, अभी तो रात ढलनी थी, अभी तो जख्म सिलने थे, अभी तो सरे ज़मीने जहाँ पे एक बादल को गिरना था, अभी तो वस्ल की बारिश में नंगे पांव फिरना था. And unfortunately, अभी ये सारे काम करने थे, लेकिन by that time आप बूढ़े हो गए और आपको इन सब कामों से रोक दिया गया. So they have given few case studies. I don't feel that we should go for the case studies, but give you an example. If a person is suffering from Alzheimer's dementia and they are already on acetylcholine esterase inhibitors, which I doubt, because unfortunately in Pakistan, the acetylcholine esterase inhibitors are not the type of the drugs which are commonly prescribed. We do prescribe memantine, which is not an acetylcholine esterase inhibitors. Acetylcholine esterase inhibitors in past, we had in Pakistan ribostigmine, we had galantamine, we had the other drugs available as well. Now I believe if you want to prescribe galantamine, in Pakistan, you have to make person search for it. And sometimes they get it, most of the time they don't. Rivastigmine, same problem. Sometimes they get, sometimes they don't. Memantine is probably the only drug which is available, which unfortunately may not be enough or may not be the drug of choice in the first place. So you have to be careful about that too. So the question is, how would you differentiate depression from dementia? Now, I want you people to respond to it. Depression involves sad mood, dementia does not. Careful clinical assessment with special attention to depression symptoms, which are less common in dementia alone, such as hopelessness, guilt, worthlessness. Treat with antidepressant and observe the response. I cannot differentiate between the two. What do you think is the best answer here? Okay, one answer is B, careful clinical assessment with special attention to depressive symptoms, which are less common in dementia alone, such as hopelessness, guilt, and worthlessness. Yes, this is the right answer, because if we have to differentiate between the two, the dementia and the depression, the first thing I always say that you have to assess retrospectively. बीमारी कब शुरू हुई, कैसे शुरू हुई, किस तरह शुरू हुई, कितने अरसे से सिलसिला चल रहा है. Usually in dementia, it's a very subtle, slow progression over the period of years, and people don't have realization that these symptoms were developing. कुछ भूल जाते चीजें, बटुए में पैसे रखे, भूल गए पैसे कहाँ रखे, चाबियां कहीं छोड़ दी, भूल गए, lack of attention span. That is the initial actually component, and then it builds up slowly over the period of years till the time they start having disinhibited behaviors, which unfortunately I have just told you. Dr. Nasir इस उम्र में आके छाबड़ी वाले से चने खा रहे थे, और so people are amazed with it कि ये क्या कर रहे हैं, इन्होंने पहले ऐसी कभी हरकत नहीं की. Well, I love to do that even now, so don't consider me to be dementic. Symptom overlap between depression and dementia. Yes. So apathy, sleep disturbances, appetite changes, poor concentration, psychomotor changes, loss of interest, social withdrawal, self-neglect, irritability, anxiety, and tearfulness. They are unfortunately common in dementia and common in depression as well. But the tearfulness in dementia is much more different from the tearfulness in depression. And if somebody knows the answer, I will definitely like to talk about it more. So, rational approach to the management of depression in dementia. So, minimize vascular risk factors. Now, this is unfortunately we miss most of the time. Minimize vascular risk factors in managing dementia and depression together. Vascular risk factors, what are they? Manage hypertension, hyperlipidemia, diabetes, hypercholesterolemia, stroke prevention, atrial fibrillation. Now, heart is weak, the brain is weak, and if both the vital organs are weak, how can you treat the person? Difficult situation. Any hyperlipidemic agent you give to a person, it will induce depression itself as well. So all the statins, they have a major side effect of causing depression. Now, at one end, we want to treat hyperlipidemia. At other end, we know that statins have a major side effect of depression. How to balance it? This is unfortunate. Again, at one end, we want to treat hypertension. But at other end, if we give some drug like levo, again, and the old drug, dopaminergic agent, something, it causes depression. So hypercholesterolemia, hyperlipidemia, stroke prevention. At one end, Allah Jannah Naseeb Kare, Professor Faisal Masood Sahab, हमारे स्टार, हमारे सीनियर, हमारे प्रिंसिपल, वो एस्पिरिन नहीं खाते थे, और वो एस्पिरिन इसलिए नहीं खाते थे, वो कहते थे कि it's better to die suddenly with a heart attack rather than taking an aspirin and developing stroke later in life. He has his own rationale about it, but this is what it is. If you take aspirin, your heart can be saved from heart attack, but you will develop stroke in the long term because of the bleeding tendencies. So this is unfortunate. How to keep a balance about it. Now, this balance is a very thin line that we have to understand as psychiatrists, understanding the physician's perspective, understanding the physician's medication, making sure that our assessment is okay, and then intervening appropriately to make sure that the management is proper as well. Now, this triad is complex. Careful clinical assessment and treat depression aggressively and comprehensively. Now, treating depression aggressively, if I write, say, Brintlex 10 milligrams to a person and push it up to 20 within 3 weeks of time, people will say, oh, he's gone crazy. He has given 20 milligrams of Rituximab where it was not necessary. वो 10 पे भी ठीक हो जाते हैं. How can you say that if a person's quality of life, if the clinical situation is not improving, I have to push up the dose? But unfortunately, if I'm pushing the dose, then I'm also addressing the renal clearance and the hepatic compromise and the drug interactions and seeing other areas as well. So judging it and managing it is an art, and you have to be good in that art. If you are not good, your patient will keep on suffering, same way as you are suffering as a physician, that your patients are not getting better. So don't suffer yourself and don't make your patients suffer because they are your patients. So there is another case scenario, Alzheimer dementia. Oh, okay, so I just talked about it. Now, Rituximab is one of the drugs that can be used and it is relatively safe, so it can be seen. मुनीर नियाजी की एक कथा है, जुर्म आदम ने किया और नस्ल आदम को सजा, गुनाह, okay, I cannot see the word, so I have to move this. काटा हूं जिंदगी भर मैंने काटा है जिंदगी भर जो मैंने बोया नहीं, जानता हूं एक ऐसे शख्स को मैं भी मुनीर, गम से पत्थर हो गया लेकिन कभी रोया नहीं. This again is common phenomena in dementia. People don't want to express because they are male. They are again, they should not cry and keep their emotions to themselves, which creates unfortunately another complication for psychiatrists to assess the person and then proceed according to that. Okay, I'm sorry, this keeps on ringing because I was just trying to put my tendencies. Okay, move forward. By no, why you are not going that way? Okay, now I got it. Okay, so findings suggest importance of routine assessment of functional status. So we have to make sure that the combined remission should be achieved. The functional remission, well, these days we are talking a lot about functional remission, and functional remission is a very complicated subject as well itself. So if we want the functional recovery in old age, a person who is 64 and retired government officer and he's just sitting at home doing nothing, what is the functional remission for that person? Question mark. And it's a big debate. So I don't want to touch this topic, and maybe some other time I will go through that and talk more about it. So limited evidence with most psychotropic agents in cognitive symptom improvement. Now, if we see generally, most of the SSRIs, they say that they have a certain level of compromise as far as the cognitive improvement is concerned. And as I mentioned in the beginning, that the symptoms in old age, passage पटवे में रखे भूल गए, थे कुछ लेने के लिए, घर से निकले भूल गए क्या लेने आया था. So very subtle symptoms, and when these symptoms are there and you have to assess them for dementia and depression and you have to treat them, and you give an SSRI, most commonly prescribed escitalopram, 10 milligrams or 5 milligrams. I have seen people writing 5 milligrams of escitalopram, which I believe is not at all a psychiatrist who should be prescribing this dosage, because I believe that a psychiatrist should understand that 5 milligrams is good for nothing. So you have to give a proper dosage of the medication if you want to get the proper response in the patient. So we are actually trying to address learning memory, attention and concentration, executive functioning, and some other symptoms associated with it as well. We have to give the dosage in a proper therapeutic level. Most of the literature is suggested that, again, the best drug, well, so far, because abhi Lundbeck वालों की presentation है, तो Rituxan is the best drug to address those symptoms. But again, the best part is that you have to understand the proper therapeutic dosage and response to it. These days, I give modafinil to people who have psychomotor retardation. Not for cognitive impairments, of course, but if the retardation is unfortunately complicated. But it has a limited data otherwise to improve the depressive symptoms. So it's not a primary drug, but it cannot be added because, again, in old age, the combination of the drugs can create more problems and complications. So you have to be careful in understanding all of these drugs. CANMAT guidelines, full functional recovery in treatment goal in major depressive disorders. As we talked about functional recovery, and I presented 1, 2, 3 presentations on functional recovery of schizophrenia. So functional recovery is a variable concept where people not only achieve the pre-morbid level, but also go back to normalcy of the life which is considered to be there. Like वो हंसेंगे, बोलेंगे, बात करेंगे, interact करेंगे, काम करेंगे, खुश रहेंगे, मसरूफ रहेंगे, वगैरह वगैरह वगैरह. So functional recovery is again viable concept, but very fluid concept, and we have to understand it before we talk about it. So I'll be just skipping this slide. So ये मैं बाद में पढ़ता हूँ, slides काफी ज्यादा हैं. So let's cover them up and then talk about it. Now, this is again a complicated issue. You give a medication, the person is taking diabetic medication, antihypertensive, congestive cardiac failure medication, and unfortunately arthritis medication and stomach medication as well. And you give him an SSRI and he starts complaining of the nausea. So what should we do? Again, it's a complicated issue. Same goes for SNRI. He starts complaining of constipation. He's already on too many medication and he now develops constipation. What to do about it? Then you have anti-constipation agent into the treatment. So things are more complicated. And then you give mirtazapine and you feel that he started gaining weight. He's already having a pot belly and you gave mirtazapine for major depressive disorder, considered to be a relatively safer drug in old age. And he starts developing weight gain. And because of the weight gain, the hypolipidemia is getting compromised, and hypolipidemia gets compromised, and his cardiac condition starts getting worse. So directly, safe drug. Indirectly, lots of complication. Now, this is what I always feel is a complication. And this is the skill that we have to understand as a psychiatrist, how to treat, what to treat, when to treat, and how much to treat. So all of these drugs we do prescribe, right? Most commonly SSRIs, then SNRIs, we all do. And safer drugs like mirtazapine and bupropion, we do prescribe that as well. People do develop side effects with that. And then what to do about it? So it's a two-edged sword, and we have to walk on it very carefully. Nausea usually with Rituxan is less. So depression is common in elderly. Low mood might not always be present. Cognitive symptoms are common in both depression and dementia. And Rituxan is relatively a safer drug in this situation. So the second case scenario is, again, Mariam would like to say something. She has raised her hand. Go ahead, Mariam. I'm listening. It was just by chance or some other thing. Dr. Mariam would like to say something. Raised hand. Oh, okay. So it was by mistake. If you want to say something, please go ahead. Stop me. Don't worry. Okay. So this is another situation where the person is having diabetes and hypertension for 10 years, diagnosed with the MDD, and then how to treat. So the question is, what will be your consideration in choosing antidepressant that is weight neutral as is insulin sensitivity, antidepressant that improves his functionality, or all of the above. Okay, B, anybody else? One answer, B, which is yes, right? So we have to give something which won't worsen his diabetes, which will not make him gain weight, and which will improve his functionality. So we have to choose a drug. And people say the rituximab is the best drug, but yes, your clinical acumen of making sure that you are not actually avoiding or missing some information in the management is most important component. So you have to make sure that you have to keep a balance to make sure that the person's diabetes, hypertension, hyperlipidemia, other complicated physical morbidities, they will not compromise with any of the treatment that you are giving. And if they are getting compromised, then you have to manage them appropriately. So mood and metabolic syndrome. So metabolic mood syndrome and behavioral emotional type, obesity, motivation and reward, neural homeostasis and genetic environment. So it's again a complex situation. Like you give an SSRI to a person, his depression is better, he starts feeling very good, but unfortunately he starts eating as well, too much. So he craves for the food, he goes out और निहारियां पावे और अपनी मर्जी की सारी खाना शुरू कर देगा और वो एक मुसीबत खड़ी जाएगी. डिप्रेशन तो ट्रीट हो गया लेकिन उसकी वजह से और बहुत सारी कॉम्प्लिकेशंस जनरेट हो गई. So in nutshell, what I want to say is that you as a physician, you as a psychiatrist, as a best judge, but please don't forget that you are treating a human. You are not treating a symptom or a diagnosis. If you remember that, things are okay. If you won't remember that, things won't be okay. जिंदगी खाक न थी, खाक उड़ाते गुजरी, तुझसे क्या कहते तेरे पास जो आते गुजरी, दिन जो गुजरा तो किसी याद की रो में गुजरा, शाम आई तो कोई ख्वाब दिखाते गुजरी, अच्छे वक्तों की तमन्ना में रही उम्र रवां, वक्त ऐसा था कि जिस नाज से उठाते गुजरी. Unfortunately, we keep on tracking various things in various stages of life, but unfortunately, we don't understand that as a psychiatrist, we owe our patients the most. So in nutshell, I'll be just finishing my presentation here. In nutshell, no dose adjustment on rituximab is needed in special population. All stages of renal impairment, mild and moderate hepatic impairment, no dose adjustment of rituximab, no effects on cardiovascular functioning. So it is considered to be a relatively safe drug. और जाते जाते राहत अंदरोही मरहूम की एक कथा फिर सुनाता जाऊं. तेरी हर बात मोहब्बत में गवारा करके, दिल के बाजार में बैठे हैं खसारा करके, मैं वो दरिया हूं कि हर बूंद भंवर है जिसकी, तुमने अच्छा ही किया मुझसे किनारा करके. If we as a psychiatrist won't raise our voice and keep ourselves in isolation, we won't talk to neurologists, we won't talk to physicians, we won't try to train the gynecologist, things won't improve at any level. So make sure that you communicate to everyone and make sure that things are okay. So learnings. Aligning treatment goal is needed in the first consultation before deciding on the medication. Cognitive symptoms are common in depressive and could be more severe if patient is suffering from both depression and diabetes. And drug-drug interaction and dose adjustments are important factors when choosing antidepressants for older population. That's all for today. If anybody has any question, they can go ahead. No question so far. No question. Okay. Either सब समझ आ गई या कुछ समझ नहीं आई. How many people do we have? 27. Okay.
Yes, sir.
Anybody, any question?
Dr. Fahad, he wants to say something.
Yep.
अस्सलाम वालेकुम सर, मेरा क्वेश्चन पता नहीं, मैंने थोड़ा लेट ज्वाइन किया, आपने ये पहले एक्सप्लेन किया कि नहीं, सिंस हम ओल्डर पॉपुलेशन की बात करें तो एट टाइम्स हमें ये इशू होता है कि कुछ इश्यूज जो हैं वो सेकेंडरी टू डिप्रेशन भी हो सकते हैं। तो हाउ डू वी डिफरेंशिएट कि ये जो मेमोरी इश्यूज आ रहे हैं ये सेकेंडरी टू डिप्रेशन है या ये रिलेटेड टू डिमेंशिया है? बिकॉज अगर तो वो सेकेंडरी टू डिप्रेशन है तो फिर तो ट्रीटमेंट डिफरेंट हो जाएगी, अगर तो रिलेटेड टू डिमेंशिया है फिर डिफरेंट हो जाएगी ओल्डर पॉपुलेशन में, क्योंकि हमारा पहला ध्यान डिमेंशिया की तरफ चला जाता है और हम समटाइम्स वो मेमोरी इश्यूज सेकेंडरी टू डिप्रेशन जो होते हैं वो मिस हो जाते हैं।
एब्सोल्युटली राइट। सो ये मैंने टच किया था शुरू में, और जो मैंने टच किया था वो मैंने उसमें यही बात की थी कि डिप्रेशन और डिमेंशिया में डिफरेंशिएट करना इज एसेंशियल। The key point is the sadness, low mood, guilt feelings, hopelessness, helplessness, suicidal ideation could be at both level, but yes, more in depressive disorders, less in dementia. So वो चीजें ज्यादा कॉमन है। और प्लस जो मैंने सबसे जरूरी बात की थी कि you see the progression of the disease. If the progression is slow and gradual, it's most likely over the period of years, it's most likely dementia. If the progression is over the period of weeks and months, it's most likely depression. But हमारी सोसाइटी में unfortunately undiagnosed depression भी कई साल चल जाता है, so हमारे लिए काम और मुश्किल हो जाता है, because हम उसको रिट्रोस्पेक्टिवली जब असेस करना शुरू करते हैं तो हमें पता चलता है कि ये तो पिछले 5 सालों से चीजें चल रही। सो इंपॉर्टेंट फैक्टर्स ये हैं, बट ऑफ कोर्स इसके बाद मिनी मेंटल स्टेट एग्जामिनेशन है, आपकी इवैल्यूएशन है, आपकी इन्वेस्टिगेटिव प्रोसीजर्स है, आपकी साइकोलॉजिकल असेसमेंट्स है, बिहेवियरल एंड साइकोलॉजिकल सिम्टम्स ऑफ डिमेंशिया को अंडरस्टैंड करना जरूरी है। सो देयर आर सो मेनी फेसेट्स टू इट, बट यू हैव टू बी केयरफुल। और जिस चीज में बार बार फोकस कर रहा था कि एज अ क्लिनिशियन यू हैव टू बी हैविंग दिस आर्ट of evaluating the person, be with the person, assessing all the things, and then proceeding with it. I hope I responded to your question.
जी सर, वो मुझे समझ आ गई। बेसिकली मेरा यही था कि लॉन्ग टर्म में तो हम डिफरेंशिएट कर ही लेंगे जब एडमिट कर लेंगे ये, लेकिन वो जो ओपीडी के 5 मिनट में बेसिकली हमने डिसाइड करना होता है कि व्हिच वे टू गो। नहीं,
ओपीडी के 5 मिनट में डिसाइड नहीं करना। अगर आपको ऐसी सिचुएशन में शक हो कि आप डायग्नोसिस स्टैब्लिश नहीं कर पाए तो द बेस्ट ऑप्शन इज टू हॉस्पिटलाइज द पेशेंट। वो ओपीडी से आप इन पेशेंट में पब्लिक सेक्टर में शिफ्ट कर दें, पब्लिक सेक्टर में, प्राइवेट में ना करना, नहीं तो लोगों ने और में सुनानी है कि अपने पैसे कमा रहे हैं। सो प्राइवेट सेक्टर में व्हाट आई यूजुअली डू इज दैट आई मेक माय असेसमेंट, आई अंडरस्टैंड देम, आई ट्राई टू कम्युनिकेट टू देम, I get the investigations, I try to get the physician's opinion, I try to cut down the number of medications they are taking, I make them have a follow-up on a relatively more frequent first 2-3 visits so that my assessment is complete, and then intervention in the meantime. So मैं उसको bits and pieces में divide कर दूंगा और थोड़ा उसको relatively जल्दी बुला लूंगा, although I know it's difficult, but उसमें आपकी गलती की गुंजाइश कम है, बजाय इसके कि आप मरीज को दवाई लिख के दे दें और उसे कहें 3 महीने बाद चक्कर लगाना। So again, that will create more problems as well. So try to be safe in this population. ज़्यादा safety is the key factor as well. Right? There, you are more than welcome. Okay, if there are no more questions, thank you very much for listening to me. I hope I was able to make some points. And of course, there were so many things that I thought that we should communicate, but maybe later on, right?
Thank you very much, sir. Thank you very much, sir. हम लोग तो पाकिस्तान में, but I would like to acknowledge your efforts कि आपने इस टाइम में जो है इस सारी चीज को प्रिपेयर किया और you have explained very well regarding the older population के किस तरह डिप्रेशन को मैनेज किया जाए। तो सर थैंक यू सो मच।
You are more than welcome. Thank you very much. 27वीं की रात है, दुआ कीजिएगा। अगेन जैसे मैंने किया कि my wife is not well and she's having some cardiac issues. So दुआ कीजिएगा कि सेहत नसीब हो जाए.
इंशाल्लाह
Thank
सर.
you very much for listening to me.
ठीक है सर.
Thank you. Allah Hafiz.
Thank you. Allah Hafiz.